First, I'm going to talk about, share with you a secret that I think is key to accomplishing the triple aim, which is better quality, better patient experience, and at lower cost. The secret is simple. It's one word, not very sexy. It is teamwork. And not just any teamwork, but physician-led teamwork. Think of a sports team. And you'll know what kind of teamwork I'm talking about. It's not the type of teamwork that you normally see in healthcare or in physician practices. It's teamwork that has a game plan, that has a strategy, that has well-defined team-centered roles. It's teamwork that has focus on score and scorekeeping, data about the performance of the team, but also the performance of the units of the team on an ongoing basis and used to systematically improve the outcomes of teams. It works really well in professional sports, and it actually works really well in healthcare. Let's take a look at some of the tactics of teamwork in healthcare, such as physician leadership that promotes teamwork. There's a common game plan. There's collaboration around the triple aim. Again, the notion of driving better quality and better patient experience, but at the same time lowering the overall cost of care. It's also the tactic of population-based healthcare is critical because that's the focus of teams in healthcare and focused on results and accountability. Quality improvement is the tool that teams use in order to drive triple aim performance. Requires practice coaching, requires good data analytics, and uses unique resources such as care coordination, shared decision making, even crazy things like group visits. Finally, teamwork in healthcare is dependent on data, dependent on aggregated data, accurate, valid, relevant, meaningful data about the quality and value of care provided and also on the cost of care provided. So let's take a look at how these tactics of teamwork in healthcare result in better outcomes. Let's first of all look at an outcomes report. This is an outcomes report on a small population of diabetics for a given provider. These are actually the results of my diabetic care, looking at the standard national performance measures of how well I do with my diabetics. The point is not how well I do, but how much better that I'm getting. Same kind of data at a practice level. So I have 11 providers, physicians and mid-level providers in my practice, and this is the aggregate data looking at our performance on our diabetics. Finally, across our community, a community of 220 providers in the North Metro Denver area, outcomes on diabetic performance. So the idea here is that in order to improve the care that you deliver, you need to first of all understand how you're doing. Understand how well you're doing according to evidence-based practice and national standards. Outcome reports are critical, but there's something missing. There's a ancient quality saying, and it goes like this, that you can't fatten the cow by weighing it. You got to do something with the data. And I'm showing you a slide now that exemplifies, demonstrates an essential tool for the purposes of fattening the cow, of improving your performance. And it's the model for improvement. It is a systematic way of defining your goals based on your data, thinking up ways to use your team to provide more efficient, effective care, and then testing these changes in your practice and then assessing the results. And in an iterative, repetitive way, improve your practice systems and teamwork workflows to result in better outcomes. So let's look at the impact of data in effective teams, in collaborations of healthcare providers, in practices, and then across a community. So let's begin by looking at diabetes. So this is a run chart, meaning the results, the outcome reports for diabetes over time. And this enables us to understand whether what we're doing in practices in our community is making an impact on the quality of care provided to our diabetic patients. If you have diabetes, you want low cholesterol. So in this particular graph, we see the yellow line with red dots is gradually decreasing, and the green line there is the national benchmark. So you want to be under that. You want your cholesterol to be low in populations of patients with diabetes. The green circles on this slide and every slide I'm going to show you are the best performing practices in our community. So they challenge our other practices to do as well. Another diabetes performance slide, a run chart on performance over time. It so happens that if you have diabetes and you smoke, it's like throwing, a match into a can of kerosene. It's bad news. Really important to identify your smokers systematically every time and never miss an opportunity to counsel, engage patients around smoking cessation. So here you see systematic improvement over a community of providers that focus on tobacco use and tobacco cessation in diabetics. And you see gradual improvement there. Best performing practice is excellent at not only identifying the diabetics who smoke, but also counseling them. This is an interesting slide because it's the same slide. Same slide focused on diabetes and tobacco use and tobacco counseling. The difference is it's more complex. It's actually showing individual practice performance in our community on the same type of data. And you see the overall performance, the yellow line, and then the individual practices, different colored lines, and almost every single practice is consistently improving over time and dramatically improving over time in this important measure of healthcare and healthcare value. The key message here is that these practices are systematically and powerfully improving the care they deliver to their diabetic patients by virtue of only competition, only sharing data. There is no money exchanging hands, there's no incentive or bonus for doing better work. It's purely the power of data sharing. How about heart disease and cholesterol? Same message. You have heart disease, you want lower cholesterol. This is performance over time. When a community of providers, of physicians, and teamwork get together and look at their data, understand what best practices really drive improved performance, and you see what you get. And then finally, medication utilization, as I had mentioned previously, real important for physicians and physician teams to be accountable for how they use healthcare resources for the benefit of their patients, to make sure that we're using the right medications for the right conditions, but also that we're not unnecessarily using expensive medications when less expensive medications will do equally well. In this case, we're looking at cholesterol medications, so-called lipid medications. It turns out that the brand varieties cost 50 to 100 times more than those of generics. So increasing the generic utilization or prescribing patterns of physicians appropriately, meaning that you're using the right medications that are equally effective, can make a big difference in cost. So you see here about a 25% increase in generic use of cholesterol-lowering medications, and that equals somewhere between $5 and $7 million of savings to our community over a period of 1 year. So very impressive. That's just with one medication. Now, Triple Aim means you don't only focus on the quality of care, you're also interested in the patient experience. Okay, the experience of care. We all know what a bad experience of care is. Having to wait 3 weeks to get in for a routine checkup, or 2 days when you have a bad sinus infection. You know what a bad experience is when you don't have a provider or a nurse who really listens to you and helps coordinate your care. You know what a bad experience is when your care team doesn't seem to be on the same page or on your page. So overall patient experience or satisfaction is critical. This just shows before and after over a period of 6 months. The ability of a community of providers, practices, working on doing a better job at access, at communication, at care coordination. And then finally, you can do all this. You can improve care. You can work on improved patient experience. But if we don't decrease the cost of care, if we don't eliminate waste, avoidable services that are not needed in order to provide better care, then we haven't accomplished our mission. The idea is not less care, but the idea really is all and only the care that our patients need and want. So in this case, by focusing on quality and patient experience for a particular payer in our neighborhood over a period of 1 year, we see a $1.5 million decrease in the cost of care, while at the same time improving the care. So decreased cost can be done while increasing the quality of care provided. So I'm going to end with a quote just for fun. And it summarizes the point being made here about data and teamwork. Data is a campfire around which organizations huddle for heat and light. The irony is that neither the heat nor the light yield the solution. The solution emerges out of the huddling. So thank you very much.